Hello, my name is Andrew Tasic. I'm an ER physician assistant at Summa Health in Akron, Ohio. Today, I'll be presenting findings from our ultrasound study, which utilizes advanced practice providers, or APPs, to perform point-of-care ultrasound on first trimester pregnancy complaints in an effort to reduce emergency department length of stay for these patients. This project was spearheaded by Dr. Quentin Reuter, who I would like to thank for involving me and being a great mentor to me throughout this process. In our practice, we found that ED length of stay for first trimester pregnancy complaints was determined to be unnecessarily long, averaging 269 minutes or 4 hours and 29 minutes. The majority of these patients are cared for by APPs with attending physician supervision, and they traditionally received a formal transvaginal ultrasound and extensive laboratory evaluation. These labs, often consisting of RH factor, cervical swabs, quantitative HCG, and urinalysis in asymptomatic patients, have been determined to be largely unnecessary or unproven to provide benefit in patient outcomes. In addition, in 2009, in a systematic review by McRae, he showed that point-of-care ultrasound performed by ED physicians has been shown to yield a sensitivity of 90% and a specificity of 98% at confirming an intrauterine pregnancy, all while being more cost-effective and reducing patient length of stay. However, studies are notably lacking on the utilization of APPs in this process. Our goal was to implement a patient care pathway utilizing APPs to facilitate point-of-care ultrasound in first trimester patients to reduce ED length of stay. A multidisciplinary team, including ED and OB-GYN clinicians, created a clinical pathway utilizing POCUS in ED patients with first trimester complaints. A training curriculum to prepare APPs to facilitate completion of POCUS, including didactics and in-person training with OB ultrasonographers, was developed and implemented. After completion of this training, APPs could perform first trimester POCUS with the supervision of attending physicians. The ultrasounds that were performed by APPs were then interpreted by attending ED physicians. We prospectively analyzed ED length of stay for patients undergoing formal transvaginal ultrasound and POCUS from December 2019 to January 2021. Because all pregnant patients were staffed with ultrasound credentialed attending physicians, POCUS was viewed as standard of care, and thus we did not monitor any safety outcomes. A total of 1,269 patients were enrolled in the study. Of these, 1,022 were evaluated with formal transvaginal ultrasound and 247 with POCUS alone. The average ED length of stay was found to be 265 minutes formal transvaginal ultrasound and 190 minutes with POCUS. POCUS utilization was associated with a 75-minute reduction in ED length of stay. In conclusion, our preliminary results confirm our hypothesis that APPs effectively facilitated POCUS in patients with first trimester complaints to reduce ED length of stay by 28.3%. We believe that further utilization of APPs to perform POCUS in these patients will further reduce patient length of stay and free up valuable time for attending physicians. Lastly, I would like to thank SAEM for the opportunity to present our work. Thank you and have a nice day.
Hello, everyone. My name is David Hadar from the University of Michigan, and I'm here to talk to you today about the effect of a longitudinal preclinical point-of-care ultrasound course on medical student performance. I have no financial disclosures. Some background information. Point-of-care ultrasound is being used in medical schools across the country more frequently now. And there's been multiple studies to evaluate the impact of point-of-care ultrasound on medical student education. There's been studies that have looked at physical exam performance, OSCE scores, procedural confidence and performance, and survey data to evaluate medical student comfort level with performing ultrasounds. Dr. Liu et al. Specifically looked at the impact of POCUS education on physical exam performance and on OSCE scores, and her study showed that there was improved performance objectively on these exams as a result of ultrasound education. However, despite all this, there is limited data otherwise to show an objective impact on medical student education as a result of POCUS education. And that's where we come in. We set out to evaluate the impact of an ultrasound course on medical student performance on specific preclinical courses and secondarily on clerkship shelf exam scores and the USMLE Step 1 exam. We hypothesized that participation in our ultrasound curriculum would improve medical student performance in sections with established POCUS applications. This is how we broke up our group. We had 178 students, of which 76 applied and 51 were accepted via a random lottery. Excuse me, as you could see in this table, we had 5 separate 3-hour hands-on sessions, and these sessions were preceded by supplemental pre-session videos. And as you can see here, the 5 sessions correlated with the organ system blocks at our institution, except for the head and neck anatomy and the procedural anatomy, which were built into the neuro block. After students completed their preclinical year, we retroactively compared the students' scores, and specifically the cumulative overall scores for cardiovascular, GI, and the neurology blocks, and in the anatomy components of those blocks as well. And then secondarily, we evaluated shelf scores in internal medicine, surgery, and neurology rotations, as well as the USMLE Step 1. And we were able to correct and control for sex, MCAT, and undergraduate degree. These are the demographics, which just show that there were no differences between the two groups. And here are our results in graph form. As you can see, cardiovascular anatomy on the left, there was a difference in the mean scores between the two groups. And looking at the rest of the groups, there was no difference in mean scores between the anatomy scores or the cumulative exam performance. And this is the same data, just depicted in table form, so you could see the numbers. The cardiovascular anatomy, there was a statistically significant difference of a little more than 3 points between the two groups. And these are our secondary outcomes. There was a difference in the shelf exam scores for surgery, but this did not meet statistical significance. There was no difference in the other two groups and no difference in the USMLE Step 1 score. So just to summarize, students who participated in our preclinical ultrasound course had a higher mean cardiovascular anatomy score. And we think that this was likely related to the fact that the cardiovascular anatomy correlates well with cardiac ultrasound. And students also had a higher mean score on the surgery shelf, but this was not statistically significant. We think that this was because surgery focuses on anatomy, and this correlates well with things like the FAST exam. Looking at the other blocks, there was no significant difference in the cumulative exam scores, and there was no difference in anatomy scores for GI or neurology blocks. And this makes sense from a neurology standpoint because there's no great ultrasound equivalent. And for GI, our institution focuses on luminal anatomy and less so on liver, gallbladder, and the biliary system, which the ultrasound application would have been relevant. And there was no difference in shelf scores for internal medicine, neurology, or your USMLE Step 1 scores. So to summarize, students who participated in our curriculum scored better in anatomically relevant units. And this makes sense since ultrasound is just an additional modality to study and reinforce the information. Does it matter? I think so. It's not just the 3-point bump in the anatomy score that's beneficial, but I think that our study, along with Dr. Liu's study and the other data that we have out there, shows that reinforcing information using ultrasound in a different way is beneficial to medical student education. So obviously this is just a start. Next steps, I think we need to further evaluate preclinical ultrasound courses over the course of multiple years across multiple institutions to better evaluate the impact of ultrasound education on medical student performance. But I think this is a good start. Thank you all. This is my email if you have any questions. Have a great day.
My name is Katie. I'm a PGY2 at UConn, here to present our study titled Impact of a Novel Point-of-Care Ultrasound Workflow on Ultrasound Performance, Compliance, and Potential Revenue. None of our authors have any disclosures to report. Point-of-care ultrasound is an important clinical tool for the rapid, non-invasive diagnosis of serious and life-threatening conditions in the emergency department. ACET recommends a robust POCUS workflow that includes standardized documentation and billing, transparent integration into the electronic medical record, and a quality assurance process. To date, most workflows have relied heavily on middleware such as QPath, for example, to facilitate documentation, billing, and integration into the EMR. However, some hospitals are reluctant to purchase third-party middleware and would prefer an in-house workflow that does not rely on external technical support, cloud storage, or additional expense. Our objective was to describe the design and impact of a novel POCUS workflow integrated into our EMR, Epic, on ultrasound performance, documentation compliance, and revenue potential. The study took place at an academic emergency department that sees 38,000 patients annually. We retrospectively looked at the 7 months before and after July 2019, when our novel workflow was implemented. In the old workflow, all POCUS exams were manually archived in the form of DICOM files, and interpretations with QA data were saved as PDF files. For the new workflow, the data was automatically generated in an Epic Crystal report, and we cross-referenced DICOM files for additional data. We used unpaired t-tests to compare number of ultrasound exams performed, chi-square tests to compare documentation compliance, and simple arithmetic for potential revenues generated. This is a diagram of our workflow. We start here with the provider at the Epic interface. First, the provider places the POCUS order, which links and sends information to PACS as well as to the ultrasound machines. The provider then selects the patient on the ultrasound work list, performs the exam, and when they end the exam on the machine, it automatically sends the information and images to the patient's chart in Epic. The provider then goes back to Epic to document a procedure note, which is linked to the images saved, and we'll show an example of the note in the next slide. Upon completion of the note, this generates a QA notification for the ultrasound director to attest and whether or not to drop charges. This is what a procedure note would look like. You can select one or more exam per note, and here you can see that we selected cardiac and biliary, and it will drop down a series of binary questions pertinent to those exams, followed by attestation questions, which can be completed by credentialed supervising attending or ultrasound director. The resident note and attestation statement, when added, are transparent to consultants and other providers. CPT codes for billing are linked to the individual smart forms selected. We found that there was a statistically significant increase in the average number of POCUS exams performed per month by all ED providers and by full-time attendings only after the implementation of the new workflow. This is a graphical representation of that same data broken down by months. On the left, you can see the old workflow, and on the right is a new workflow. The blue represents all providers, and the orange represents attendings only, without the help of a resident. As you can see, the dotted lines representing the average number of exams performed by both groups increase with the new workflow. We measured areas of non-compliance for both workflows, as well as exams were fully compliant in documentation. Compliance was defined as the inclusion of the patient's first and last name, medical record number, name of the operator performing the ultrasound, acquisition of POCUS images, and documentation of an interpretation. There was a statistically significant increase in the number of exams that were performed in compliance after implementation of the new workflow compared to the old workflow. We took those exams that were complete by attendings only and were fully compliant and broke them down into exam types and potential revenues generated using the 2020 RVU conversion factor. You can see here that there is a large increase in potential revenue with the new workflow from 500s to 22,000s. There were several limitations with our study. This workflow was implemented at a single institution and integrated into the Epic EMR. It is difficult to determine whether this workflow could be adapted into other institutions, especially ones that do not utilize Epic for their EMR. Secular drift is inherent, but we tried to minimize this by analyzing the months closest to the workflow change. And finally, there was paucity of POCUS reimbursement information from our institution's billing department. In conclusion, a robust emergency department point of care ultrasound workflow without the purchase of third-party middleware can be seamlessly integrated into the Epic EMR and result in an increase in POCUS examination, documentation compliance, and potential billable revenue. We would like to thank Rob Fuller for prioritizing the development of our novice POCUS workflow at our institution, and Patricia Siegel and Claudette Shaligan for their help in making it happen. Thank you for your attention.
Hi, my name is Brandon Woobin, a current third-year emergency medicine resident at the University of Iowa. On behalf of my co-authors, I want to thank SAEM for the opportunity to present our study on long ultrasound in emergency department patients with symptoms of severe acute respiratory syndrome, coronavirus 2, better known as COVID-19. I have nothing to disclose. We'll go over the background for this study, our methods, results, and conclusions. We started this project in spring of 2020 when not much information was available about COVID patients, except for case reports and some small studies from China and Italy reporting some typical findings for lung ultrasound in patients with COVID. There was some evidence that lung ultrasound correlates well with chest X-ray and chest CT findings, but no good prognostic studies. Essentially, it's relatively easy to perform lung ultrasound in the emergency department, but the problem is knowing what to do with lung ultrasound findings and the significance for patients with prognostic value. Our objective was to see if an abnormal lung ultrasound was associated with hospital admission, with a secondary objective of examining how lung ultrasound findings correlate with nasopharyngeal swab PCR testing. We enrolled a convenient sample of 38 emergency department patients with symptoms suspicious for COVID. We used the Butterfly IQ system, which is a portable handheld solid-state device that connects to a tablet. It was chosen because it could be easily sanitized going in and out of rooms with isolation precautions. Each patient had 14 long windows examined, looking for B-lines, subpleural consolidations, or effusions, air bronchograms, pleural effusions, or irregular or thickened pleural lines. We then called patients on days 3, 7, and 14 following their initial emergency department visit and asked them what their current oxygen saturations were and if they were febrile. Not all patients had home pulse oximeters, but at that time our hospital was distributing them as part of kits for people who were tested. We also performed chart review at 30 days to report mortality, hospital length of stay, and any return visits to the emergency department. We were able to enroll 38 patients, predominantly male, median age in the 40s, generally obese with a median BMI in the mid-30s. Patients with an abnormal lung ultrasound, any finding other than normal A-line pattern or normal B-lines. 71% of those patients tested positive by nasopharyngeal PCR for COVID, compared to 70% of those with a normal lung ultrasound, which is not significantly different. When compared to nasopharyngeal PCR for COVID as the gold standard for diagnosis, an abnormal lung ultrasound had a 74% sensitivity and 27% specificity. With respect to prognosis, 71% of patients with an abnormal lung ultrasound were admitted to the hospital compared to 40% with a normal ultrasound, which trended towards but did not reach significance. At all 3 follow-up time intervals, none of the patients with a normal lung ultrasound were hypoxic. And of those that were admitted to the hospital with a normal lung ultrasound, all of them were discharged by hospital day 6 with no 30-day readmissions. We pre-planned to record specific abnormal findings for each patient with the intent of examining which abnormalities might be more relevant for differentiation than others. For patients with COVID by PCR, 44% had fused B-lines or diffuse opacities, compared to 9% of those who were COVID negative. 50% of admitted patients had fused B-lines or diffuse opacities, compared to 7% of those who were not admitted. The abnormalities we identified on lung ultrasound for patients with COVID were similar to the findings that have previously been reported, such as subpleural consolidations, pleural line irregularities, and B-lines. It's important to note that there is significant overlap with some of these findings with other disease processes, such as ARDS and pulmonary edema from heart failure. While our study found relatively low sensitivity for lung ultrasound for the diagnosis of COVID compared to PCR, other studies have shown higher sensitivity, but they incorporate a degree of clinical suspicion. We did not record data on clinician pretest probability based on clinical suspicion. This study has some limitations. With only 38 patients, this was a fairly small sample and was conducted at a single academic center. We designed this study early in the pandemic, and our hospital system was able to divert a lot of non-critically ill patients to telemedicine and a specific clinic for respiratory illnesses not in the emergency department. While patients with pathologic B lines were associated with admission, clinicians were not blinded to the ultrasound findings. Thus, they may have been seeing these significant lung ultrasound findings and being more likely to admit patients than they otherwise would have. In conclusion, in this small, convenient sample of emergency department patients presenting with symptoms of COVID-19, greater than 3 or fused B lines were associated with hospital admission and a positive PCR test, but an abnormal lung ultrasound was neither sensitive nor specific enough for diagnosis of COVID-19. Thank you.
Hi, my name is Andrew Goldsmith, and I'm the Director of Emergency Ultrasound at Brigham and Women's Hospital. And today I'd like to talk to you about point-of-care ultrasound for differentiating influenza from COVID-19. Now, unfortunately, I have no financial disclosures. Now, influenza and COVID-19 patients often present with very similar symptoms. Now, normally that would not be an issue. However, when you have two diseases that require vastly different treatments or lead to very different outcomes, this can be an issue. Now, lung ultrasound has evolved into a powerful COVID-19 diagnostic tool. Now, eventually, influenza and COVID-19 will coexist, even though not currently right now. And then differentiating between those two, when that time comes, will actually be needed. Now, the goal of this study was to determine whether emergency physicians can accurately differentiate between COVID-19 and influenza infections using only lung ultrasound. Now, to do this, we did a cross-sectional study of patients presenting to the ED with flu-like illness. To do this, we did a convenient sampling of them. Now, all patients were PCR tested for COVID-19 and or influenza. Now, the study started in December of 2019, and therefore we started only with influenza, but by March of 2020, we actually combined it to COVID-19 and influenza patients. Once enrolled, all patients received a 10-zone lung ultrasound, as you can see on the right here, 4 lung zones anteriorly, 4 lung zones laterally, and 2 posteriorly. Now, based on the PCR testing, patients were put into 3 subgroups. Patients were put into influenza, COVID-19, or neither. Based on the lung ultrasound, 4 ultrasound fellows were blinded to PCR results and reviewed those ultrasounds, and they reviewed them for B lines, subpleural consolidations, irregular pleural line, or pleural effusions. Now, if there was a split between the 2 fellows, an ultrasound ED attending was the overreading counted as the final decision. Based on this read, a modified subalti score was then calculated for each lung zone. As you can see on the right, a score of 0 was a normal lung, a score of 1 was a pleural line irregular and maybe 1 or 2 B lines, and a score of 2 was a broken pleural line, subpleural consolidations, or 3 or more B lines per clip. Now, since this was per each lung zone, a patient could have a maximum of 20 points. Now, for our results, so we had 252 patients convenient sampling present to the ED with viral symptoms. Now, of those, 165 went under a 10-zone lung ultrasound. Based on that, only 7 of those scans needed an overread by an ED ultrasound attending. And retrospectively, 51 had influenza, 56 had COVID-19, and 58 were neither positive by PCR for COVID or influenza. Based on this, we did a multivariate regression analysis. Now, up top, you'll see the regression analysis showed that irregular pleural, subpleural consolidations, B-line, and pleural effusions were all statistically significant variables for determining that COVID-19 is a diagnostic outcome. Now, since agents heart failure actually had statistically more patients in the COVID group, we actually adjusted our results for that. And based on that, we came up with B-lines and pleural effusion as the only 2 variables as being diagnostically significant for COVID-19. And when I say pleural effusions, I mean the absence of pleural effusions, as the odds ratio is less than 1. Now, based on that multivariate model, we did an ROC curve, and that ROC curve generated an AUC of 0.82 as COVID-19 as a diagnostic outcome. And based on the results, we did a modified Salati score. And as you can see, COVID-19 had a statistically significant higher score than both influenza and neither. And based on this, we can basically show that lung ultrasound can help ED providers differentiate between COVID-19 and influenza. And my guess personally is that if you combine this with both the physical exam and history, those test characteristics will improve that much more. Now, specifically, B lines in the absence of pleural effusions were more associated with COVID than other diseases with flu-like illnesses, such as influenza. Now, even more further, a scoring system will help providers delineate between those disease states even more. So I'd like to open this up to questions, but before doing so, I want to thank Dr. Hamid Shikui, Andrew Lateplo, Irene Ma, Oni Eki, Nicole Duggan, and Ahadal Saad. Thank you, and I look forward to your questions.
Hello, everyone, and thank you for joining today to discuss our description of the natural history of ventricular fibrillation on TEE as described in the PIG model. My name is Patrick Fink, and I'm a senior emergency medicine resident at the University of Utah. I have no disclosures to make. Some brief background. Ventricular fibrillation is the most common rhythm in cardiac arrest, and rates of successful defibrillation decline the longer that our patients are in this rhythm. Transesophageal echocardiography is a useful tool for guiding cardiac arrest resuscitation, letting us correlate electrical activity on the monitor with cardiac motion, helping to identify causative underlying pathologies, and for the detection of recurrent arrhythmia. Because withholding defibrillation in the setting of shockable rhythm would be unethical, the natural history of ventricular fibrillation as visualized on TEE has not been described in humans. In the course of conducting ECMO research in the PIG model, we developed observations of a consistent pattern of TEE appearance during ventricular fibrillation without intervention. Our goal in this work was to characterize the natural history of ventricular fibrillation in the PIG model, potentially to guide prognosis and treatment in patients received from the field with unknown duration of arrest. To this end, we introduced a pacing wire into the right ventricle through an internal jugular central line, and ventricular fibrillation was induced with current from a 9-volt battery. Images were then collected by TEE throughout VFib and after fibrillation. This was repeated across 9 pigs, and the definition and duration of the stages that I'm going to describe to you were determined by consensus. I'll now review the 3 phases and then approach each individually. In the first phase of VFib after induction, fibrillation is grossly apparent, and the left ventricular chamber is well visualized. In the second, fibrillation becomes progressively more fine, and blood within the left ventricle develops internal echoes and swirling. In the third and final phase, the ventricle is opacified, and fibrillation is too fine to be seen. Atrial contraction is present, but gradually decays as well. This slide, which we'll call phase 0, is to familiarize you with the relevant anatomy, and to show the induction of ventricular fibrillation in the clip at the right. The images that you will see were acquired at the mid-esophageal long axis view, which for those less familiar with transesophageal echocardiography can be thought of as a vertical mirror image of the transthoracic peristernal long axis view, approaching these same chambers along the same axis but from the posterior of the heart. For purposes of comparison, note the clear myocardial and endocardial definition present at induction, as well as the same familiar chambers from the transthoracic view, the left atrium, left ventricular outflow tract, right ventricle, and left ventricle. Here we move on to what we call phase 1, or early fibrillation. Fibrillation of the ventricle is grossly apparent, atrial contraction is organized with valve movement present, and endocardial definition is preserved. This phase persists throughout the end of the second minute of ventricular fibrillation. In the second phase, beginning around the 3rd minute of fibrillation, internal echoes are observed in the left atrium and left ventricle, defining what we call phase 2. During this phase, fibrillation is fine but remains apparent on TEE, and atrial contraction remains organized. This phase is defined by those internal echoes. The third phase is marked by a pacification of the ventricle by internal echoes, with loss of endocardial definition. This begins at around 5 minutes, at which time the atrial contraction persists but will then decay. Finally, as we observe extended fibrillation in the third phase, you can see decay of atrial contraction out to about 15 to 20 minutes, with persistent and profound ventricular opacification. In conclusion, we have observed a consistent pattern of 3 ultrasonographically apparent stages in ventricular fibrillation. These are defined by gross fibrillation with good left ventricular visualization, then fine fibrillation with internal echoes developing within the left ventricle, and finally absent fibrillation with opacification of the left ventricle, loss of endocardial definition, and decay of atrial contraction. While this was conducted in a porcine model, it raises questions as to a similarly replicable pattern in humans. Does atrial decay follow a quantifiable pattern? Does the amplitude of visible ventricular fibrillation follow a replicable pattern? Could ventricular opacification be a marker of pre-hospital CPR quality? These are all potential areas for further research. And with that, I thank you for your time, and I'd be happy to take any questions or any discussion.
Hello, my name is Jamie Gullickson, and I am a researcher at Mass General Hospital. On behalf of my team, I would like to present our abstract, Echocardiographic Predictors of Mortality in Cardiac Tamponade. There are no conflicts of interest to declare. Pericardial tamponade is a life-threatening diagnosis with a high mortality. Echocardiography is the gold standard diagnostic modality for pericardial effusion and tamponade. The objective of this study is to determine which echocardiographic findings are predictive of mortality and ICU admission in patients with pericardial effusions. This was a retrospective cohort study performed at 2 large tertiary institutions with a combined annual census of 185,000 patients. An EMR query was performed in Epic to collect all patients that underwent a pericardiocentesis. The inclusion criteria were adult emergency department patients with pericardial effusions who had a pericardiocentesis within 48 hours. Exclusion criteria were pediatric patients, trauma patients, and patients who did not have a TTE. Demographic data collected included age, vitals, and past medical history. Echo findings collected included right ventricular diastolic collapse, right atrial systolic collapse, IVC plethora, exaggerated mitral valve inflow velocity, and effusion size. These variables were used to create an ROC predictive model for ICU admission, 30-day, and 1-year mortality. In total, 236 patients met the criteria, 57% of which were female. The mean age was 60, with a standard deviation of 14.8. The most common past medical histories were malignancy, anticoagulant use, prior pericardial effusion, and recent cardiac procedures. This is the result of the TTE findings. Right ventricular collapse was the most common, which was seen in 69% of patients, and right atrial collapse was the least common echo finding, seen in 53% of patients. Our model showed satisfactory performance and discrimination with goodness of fit greater than 70% in the 30-day and 1-year mortality, with high accuracy and high sensitivities, but low specificities. There was no single variable that was significant enough to reliably predict the outcomes of interest. Performance of the model is limited by a small sample size and lack of a powerful predictive variable. In conclusion, in this model, there was no echocardiographic finding that was predictive of ICU admission, 30-day mortality, or 1-year mortality. Future research should include larger sample sizes or stronger predictive variables. This is a QR code link to references. Thank you for your attention.
Hi, my name is Nazay Gulech. I'm an ultrasound fellow at New York Presbyterian Brooklyn Methodist Hospital. Today I'll be sharing the results of our study titled Contamination Rates Between Sterile Covered and Uncovered Probes for Ultrasound-Guided Peripheral IV Lines. We have no financial associations to disclose. According to the CDC, the United States spends anywhere between $28 billion to $45 billion annually on hospital-acquired infections. Recently, in 2018, AIUM and ASAP both released disinfection guidelines of ultrasound probes. However, neither provided agreed-upon step-by-step protocols for disinfection of ultrasound-guided peripheral IV lines. Our hospital protocol requires low-level disinfection and no probe covers for ultrasound-guided peripheral IV lines. Administrative and regulatory bodies often mandate policy changes. However, they often do not fund these policy changes, and the responsibility to fund them falls on the hospitals or the specific departments. We hypothesize that contamination rates for uncovered probes will be the same as sterile covered probes in ultrasound-guided peripheral IV lines. This was a randomized non-inferiority study using a convenience sample. We followed PIC team nurses who perform ultrasound-guided peripheral IV lines on admitted patients, which had been ordered by the clinical team. After the placement, if the patient was randomized to use a sterile probe cover, the cover was removed. Then the process as follows was the same for both covered and uncovered probes. The probes were first wiped off with a dry towel, then with a 55% isopropyl alcohol wipe, and finally allowed to dry for 2 minutes. At this point, the probe was ready for next use. Then the clean and dry probes were swabbed, and the swab was inserted into a System Sure Plus ATP detecting luminometer, which detects adenosine triphosphate, hence the presence of organic matter. The machine yields prompt results. Results are reported in relative light units, RLU, and RLU less than 25 is defined as clean and less than 10 as sterile. Our results are as follows. The mean relative light unit for the experimental arm was 0.34 with a median of 0. For the control arm, the mean relative light unit was 2.29 with a median of 1. 2 results included in the control arm were protocol violations. However, they were still less than 25, hence clean. We also did a cost analysis using the cost per cover and extrapolated its annual use. Each sterile probe cover cost $8.49. 2,030 ultrasound-guided peripheral IV lines were completed over 8 months. Mean utilization was 254 per month by the PIC team, resulting in a calculated incremental cost of $25,852 per year. This study shows that uncovered probes undergoing low-level disinfection have the same cleanliness as sterile covered probes. Hospital-acquired infections are detrimental to patients and a financial burden to hospitals and the US economy. But ultrasound-guided peripheral IV lines may not be a substantial contributor to these burdens. In this light, we have a study that shows that unnecessary costs could be averted by not having regulatory changes enforcing sterile covered probes for ultrasound-guided peripheral IV lines. The incremental cost if we use probe covers does not even include the ultrasound-guided peripheral IV lines done in our emergency department, so this cost would actually be much higher. These are my acknowledgements. These are my references. Thank you very much for listening and have a good day.